Good evening, everyone. We welcome you all to OrthoTV original webinar series. And today we have with us a very good friend and a senior joint replacement arthroplasty surgeon from Mumbai, Dr. Girish Dewnany. His training is mainly been done in UK and he is attached to Hinduja Healthcare and Bombay Hospital besides various other hospitals in Mumbai. So, and we thank our supporters who has given us an unrestricted educational grant, Dr. Reddys Lab, the makers of Ultranise and Nise Gel and Omez. So over to you, Dr. Girish.
Okay, good evening, everybody, and thank you, Neeraj, for giving me a chance to share my views on hip arthroplasty in the trauma scenario. Now, this is one area where there is interest of both the trauma surgeon and the arthroplasty surgeon. To be very honest, most of us do trauma, and some of us also profess to do arthroplasty in addition to that. The talk today is going to cover these four groups of patients, and it will be restricted to femoral fractures and how they lend themselves to needing an arthroplasty as and when required. The first group will be an arthroplasty for displaced intracapsular neck femur fractures. Second group will be salvage hip arthroplasty for problems coming up from previously done bipolar arthroplasties for transcervical fractures. The third group, if extracapsular fracture fixation fails, how do we salvage that and where is the place for arthroplasty in it? And last but not the least, the new field which is getting prominent now is doing a primary hip arthroplasty for an extracapsular proximal femoral fracture, especially in the above 80 elderly population. What this talk will not cover will be hip arthroplasty post acetabular fractures, because that is a big topic in itself, and you could have arthroplasty performed for the fresh acetabular fracture or a delayed presentation, and neither will it cover periprosthetic fractures post hip arthroplasty, which again is a separate and a rather detailed topic and beyond the purview of this presentation. So let's go to the first group, which is the intracapsular neck femur fractures. Now, we all know that hip fractures in general account for over 2/3 of hospital bed stays, and they all have a recognized annual mortality rate of 30%. Now, these are figures coming from the developed countries, and the third world countries are no different. There is an associated loss of independence, and there is a big impact of comorbidities on this group of patients as they are the elderly group. So an appropriate management for them still remains a matter of controversy. This population does have a limited life expectancy, but with today science in general and medical science in particular advancing, the life expectancy does get increased and longevity is more. These fractures require the patient to be satisfied with the early treatment and have a reasonably good long-term function. So the demands on the operating surgeon are that much more. Coming to intracapsular neck fractures, we are all aware of the Garden classification, and fair enough that we know that an undisplaced fracture, we would do a fixation, whether a cancellous screws or a short DHS. It's the displaced fractures where there is a discussion whether we should subject them to an ORIF or do an arthroplasty. Again, that is a discussion which is still ongoing, and we see what literature supports us in that. So undisplaced fracture of this nature would definitely be simple, and you get a multiple CC screws for it. If there is a fracture which is slightly more displaced, then the option would be to do a 2-hole DHS with a derotation screw. Though I admit that personally, I am a big fan of this implant other than the CC screws, because I prefer some hold in the proximal shaft as well. And these do reasonably well, provided the patient is operated in time. Patient can comply with instructions of delayed or non-weight bearing, and the blood supply is not terribly damaged, because there is always a risk of AVN which persists for up to 2 years post-surgery. It is the displaced fractures which have options which can be discussed. You can either do a monopolar or a unipolar prosthesis like the Austin Moore. You can do a cemented bipolar, as in this case. You can do an uncemented bipolar, as in this case. or you could do a total hip replacement. All these are valid treatment options, and the decision of what is good and where is a matter of individual patient selection and doctor judgment. What does literature say regarding our choices for a displaced neck or femur fracture? So, if you, one of these papers comparing internal screw fixation with the bipolar taken from the Norwegian Arthroplasty Register very clearly mentioned that compared to ORIF, the initial difference in 1 year mortality was not very different, 27% to 25%, but there were significant differences found in reoperation rate, pain at the end of 12 months, and dissatisfaction rate at the end of 12 months, including lower quality of life scores. So it was concluded that the displaced neck or femur fractures, especially in the elderly, should be treated with some sort of replacement. In this paper, it was hemiarthroplasty. Again, a randomized comparison of reduction in fixation versus replacement showed very clearly that there was a higher reoperation rate with ORIF, much lower rates with hemiarthroplasty or total hip arthroplasty. The functional outcomes also were poorer in ORIF, and healthy patients with displaced neck or femur fractures should be offered arthroplasty as the preferred option. These are all literature studies, and in today's world, I think it makes sense to follow these evidence-based guidelines, especially in the older group of patients. However, anybody younger than 50, I would still opt towards fixation, but in anybody older than that with a displaced neck or femur, my preference would be towards an arthroplasty. So femoral neck fracture is displaced. Our IF doesn't have as good a long-term result as a arthroplasty, whether it's hemi or total is a matter of choice. Now, when we come to arthroplasty, what do we prefer? Do we prefer unipolar or do we prefer bipolar? This study from the UK compared these two groups and felt that cementless bipolar arthroplasty was far better in terms of functional use in a more active patient with a fracture neck femur. Cementless or cemented is another discussion which we will just touch upon briefly in a minute or so. You can see in this table that the mortality rate was far less in patients having a bipolar as compared to a unipolar hemiarthroplasty, and it was statistically significant. The importance of a bipolar is underlined by this study again from the UK, which shows that the incidence of erosion of the articular surface of the acetabulum was far less with a bipolar. So today, the unipolar is not holding its own, and bipolar has virtually taken over the bulk of the hemiarthroplasty cases. It can be argued that the bipolar stopped functioning like a bipolar in a few months' time, but that is a debate which is still persistently ongoing. If you see the Australian registry, cumulative revision rate of primary partial hip replacement, the bipolars are far better performing in that compared to the unipolars, whether they are monoblock or modular. The bipolar is far better, as seen in the yellow graph at the third of the and the bottom graph. Now, what about total hip arthroplasty compared to hemiarthroplasty? Would you offer that as a first choice? Again, this paper from Korea, Journal of Arthroplasty, seems to have a situation where the total hip arthroplastic patients were performing better, reported less pain, and less likely to require repeat surgery. So they had a higher but not a very significant dislocation rate, and this has to be kept in mind for anybody offering that to their patients. So the evidence is there for total hip arthroplasty, but in 2009 it was not strong enough. But papers subsequent to that have had a good case to do total hip in a physiologically good patient. Again, another paper of a meta-analysis of what is better, hemi or total hip. This is from 2012 in the Journal of Arthroplasty, a meta-analysis. 1,200 patients. Post-op mortality, infection or mortality, same for both groups, but the THA patients had lower pain rates and lower reoperation rates, while the hemiarthroplasties had a lower dislocation rate, and of course a shorter operative time and less blood loss. So the patient choice should be on the patient's physiological state, the functional demands, and the presence of comorbidities. So it's an open debate, and it does depend on a patient to patient and surgical experience as well. Another paper showing a randomized trial follow-up from Sweden that in elderly lucid patients above age 8 till the age of 80, THA offered significantly better results in terms of hip function and quality of life. They did not find any higher dislocation rates in this study. So the message here is, the patient is physiologically well enough, then it is no doubt that there are better outcomes with the total hip arthroplasty. But if doing a total hip arthroplasty for a neck femur fracture, you have to be focusing on your technique, the main area being to decrease the risk of dislocation. There is another controversial top issue is whether should we cement these femoral stems that we put in, whether it's total hips or bipolars. Studies have not shown a huge difference. And one studies from the OTA papers shows that both cementless and cemented prostheses are equally effective in their presentation, with not a great deal of difference in terms of perioperative complications or functional outcomes. Another paper from the CORR very clearly highlights the similar situation. And it says that you select the stem for hemiarthroplasty that perform well as a total hip arthroplasty to optimize the outcomes for patients. The only thing the cementless hemiarthroplasty had was a shorter duration of surgery. But if you see these two graphs from the Australian registry in 2012, the cemented stem, which is the blue graph, shows a lower operation or revision rate at compared to the cementless stem. And in case of unipolar hips also, the cemented revision rates are a little lower, but they tend to get higher as the time goes on beyond the first 7 to 8 years. So in conclusion, they say that when you're managing a displaced femoral neck fracture, consider the patient's physiological age, the life expectancy, the functional requirements, associated comorbidities, bone quality. This is an important component when we are discussing cemented versus uncemented, and of course, mental state and compliance. Because if you have a patient who is unable to follow the requirements of restrictions placed upon him or her post hemiarthroplasty or a total hip arthroplasty, then a disaster is just around the corner. So in these patients which have compromised mental states or cognitive differences, a bipolar hemiarthroplasty certainly gets my vote. So what are the ongoing controversies, which I'm not going to discuss in detail here, but just touch upon briefly. First is the type of approach. So many surgeons that I have interacted with say, oh, we do our total hips through a posterolateral approach, but we do our bipolar hemiarthroplasty through an anterolateral approach because that decreases the risk of dislocation. So I assume the posterolateral total hips are done for cases of arthritis, while anterolateral approaches are chosen because the patient does not have any uh, reason to be stable or unstable. Cemented versus uncemented, the risk of cement implantation syndrome is a real possibility, and medical comorbidities also dictate whether we use cement or use a stem without it. This has not been borne out by any sort of literature study as such, but there are papers which are proponents of one group over the other. Bipolar versus total hip we discussed is as per physiological age, and it depends clearly on the patient's general profile. Interestingly, newer bearings like the dual mobility is a important asset to have in case of neuromuscular and cognitive problems in patients. Patient profile and fracture profile both are crucial in coming to a decision. And my personal view is horses for courses. So cases where there are options to give a good physiologically outcome, then total hip arthroplasty. In those which have got cognitive issues, I lean towards the bipolar or towards the dual mobility type. Cemented versus uncemented, I tend to offer the cemented option as first option in an older age group where I'm not sure of the bone quality. The uncemented stem is kept as a backup if I find patient with exceptionally good cortical bone or somebody whom the anesthetist feels we should avoid cement in then that's the uncemented system. My approach, of course, is the anterolateral for all, whether I do a total hip for arthritis or for trauma, so there's no controversy there. This is an interesting situation where I had to do a primary constraint hybrid hip replacement for a gentleman, for a lady who was 95-year-old and completely demented. The family being very clear that it should not dislocate come what may, and she was not somebody who could respond to commands or obey instructions. So you, as I said, horses for courses. You have to know when to offer what. The patient profile dictates that, in addition to what the bone quality and the type of injury is. Now, bipolars are something which we all do, and they do have their share of problems. I'm going to share a few cases to just illustrate what can go wrong with a bipolar done primarily for an intracapsular neck femur. This slide clearly shows that my next few slides are not going to be those with lots of theory, but only cases to illustrate a point and then to highlight what that a bipolar on its own is not the panacea for everything. So the first case we are discussing is something called an intrapelvic protrusio of a bipolar prosthesis. This was a lady with 5 years post bipolar hemiarthroplasty who presented with sudden onset pain and difficulty to walk. And she did have underlying osteoporosis. Unfortunately, at the end of the bipolar prosthesis that was inserted, there was no medical management of osteoporosis initiated. She did not have any rheumatoid issues. This necessitated a surgery wherein I had to use a rim fit cup to reconstruct the acetabulum, going as per principles of protrusio hip reconstruction. On the femoral side, the stem had to be revised using what is called an ETO, or an extended trochanteric osteotomy, and using a distal fixing stem. There was bone graft on the medial side. The lady went on to consolidate very well, both on the acetabular side, which is where the bone graft is being seen, and on the femoral side, where the ETO shows good healing in in the initial 2 years. And she maintained this at the 4-year stage also. She did use a walker because she was having some issues of balancing because of early Parkinsonism, but otherwise was extremely comfortable with her hip. So a bipolar is not something which you do and forget about. It can come back to haunt you with interesting problems. Second patient is a lady of 68 who had a bipolar done somewhere else, presented with right thigh pain. I thought maybe the bipolar was causing acetabular erosion, took her up for exchange of a bipolars to a total hip arthroplasty. But to my surprise, this is what happened, and this is something which we are seeing quite frequently, especially in situations where we're using an Indian local-made bipolar stem, where the metallurgy is questionable, and maybe in hindsight, I should have noticed a small little crack which was visible on the X-ray, but this was something which did catch me off guard. And I implore all of you all to please be very careful as to what bipolar stem you are using, especially if you're using the Indian made, because the question of quality is still very, very unclear. She required to have a full-blown total hip replacement. I had to do an extended trochanteric osteotomy. This time, I had to do it from the anterolateral approach, as I was already committed to that approach, but she went on and did very well. So we did talk about two cases using the ETO, and just a couple of slides on what exactly an ETO does. It takes off the 1/3 of the perimeter of the femoral shaft, best done via the posterior approach. And we can flip the shaft open, take off the cement or the well-fixed uncemented stem, and then reconstruct it with a distal fixing stem. So this is how a femoral component is extracted in case it is an uncemented, well-fitting stem. It has its benefits, and it is used quite extensively by us in our revision hip practice, like in this patient where the total hip arthroplasty, the acetabulum had to be revised, but the femoral component was well ingrown, and the only way to remove it was using an ETO, which was then wired back using cables, and the acetabular cup was revised. Problem number three is, okay, you're done a bipolar and it dislocates. What do you do then? Uh, you can go back and do a close reduction, but remember that the soft tissues have been disrupted. And unless you go and repair those soft tissues, you are going to have this risk again. Now, there is no guarantee that if you do repair the soft tissues and they are not of very good quality, the problem is going to recur. So in this particular patient, there was an episode of dislocation. This was the third episode in a period of 8 months, and both times she had been reduced closed, but this time was fed up and did not want to enter that risk again. On table, the stem, I did do an open procedure for her. On table, the stem was well aligned. The version was okay. So I just converted the bipolar into a constrained total hip replacement. She was 84 or 85 years of age, and this would be an ideal implant for her. And I was sure that she would now not dislocate till the rest of her life. Uh, in this scenario, today you can also offer her a dual mobility option if the stem is compatible, but I would not be keen on changing the stem because that would then entail a very big procedure like an ETO, etc., etc. So the dual mobility option is available, but only with a compatible system. Another patient where there was an uncoupling of the femoral head from the bipolar cup. Never seen this before, but did present to us. And the only option for her was to convert her to a total hip replacement. You could see the uh, ETO here that has been done. And people can have a look at the 5 months post-op of how well this Proxima ETO heals up very well. You have to be sure that the soft tissue is maintained, whichever approach you do it by. And once you get the alignment proper with the distal fixing stem, the ETO usually heals up without too much problem, and the patient does not have any limp either. Last but not the least, this is a patient who had a bipolar done elsewhere, complaining of persistent pain, and you can see how the bipolar has been put in a varus alignment. Somebody has excessively taken off the medial wall, and the only option left was to convert her to a total hip arthroplasty with a long stem bypassing the defect in the lateral wall that had been created by the earlier bipolar that had been inserted. So these are a few examples of how bipolars can get into problems. Of course, there are periprosthetic fractures, as I said, which are not a part of this presentation, but that is again a new trauma which causes the problem. So I have not included them here. These are problems which are dependent on the primary bipolar that has been done for intracapsular neck femur. So now we move on to our second group of cases, which is the extracapsular hip fractures. And there are two components in this section. The first is arthroplasty in failed proximal fracture fixation. It has its own challenges and unfortunately is being seen regularly in spite of good implantation available to us now. So these hip fracture patients, as we initially discussed, are an aging population. They definitely have underlying osteoporosis, ladies more than men. Uh, we are seeing more of these cases because of inadequate fixation. Interestingly, Western results are not always applicable to our patients. When we were in the UK, when I did a DHS, we made them walk at 48 hours, forgetting and did not bother to see them again because their quality of bone was excellent. But the patients we see here have a different beast of a fracture. The fracture tends to just explode on us literally because of osteoporosis. So we have to have strategies addressing the type of cases we see in our practice. This is the type of cases that we are talking about here, patients who have had DHS fixations but have either got implant cutout or perforation of the acetabulum because of failure of the implant in the femoral neck. So all these cases are challenges in their own right. We are not again discussing intracapsular fractures which have failed. That is a different issue. Or we're not even discussing in this ABN presenting post-fracture fixations. Uh, we are discussing only extracapsular fractures which have been fixed and unfortunately have not been successfully fixed and have had to have salvage arthroplasties. So this is a classical example, extracapsular intertrochanteric fracture fixed with the DHS, looks pretty good on the initial post-op X-ray, but over the next 6 to 8 months, progressively the head falls off into varus because of a poor bone quality, and the collapse of the DHS has been stopped, and we have to then revise this to a hemiarthroplasty because the will depend on the quality of bone. So these patients have an advanced age problem, and we need to do surgery which is definitive and will allow them to mobilize early. So bipolar hemiarthroplasty or total replacement is an option which we will discuss, which is the most suitable. One of the most important steps is that you have to rule out infection. That is the stage one before we embark on reconstruction of these cases. The first issue is to dislocate the hip and then remove the implant so that your exposure and your approach is not compromised with the implant which is in situ and may have cut out in a fashion which may not be approachable by the conventional approach. Use an approach that you're familiar with, and in some case, patients who have a stiff knee, anterolateral approach would be the preferred option, even for those surgeons who are used to posterior approach surgery. A challenge is for a prosthesis operation done after a failed proximal fixation are due to basically altered anatomy due to the primary fracture. There may be some evidence of non-union or malunion. There is definite proximal bone loss. There are previous holes from the previous implant which impede our reconstruction options, and the poor bone quality due to underlying porosis. The femoral neck, in my humble opinion, cannot tolerate more than one track. And if a refixation is tried, then there's a huge risk of cutout. So for me, in these fractures, when operated primarily, get it right the first time. GIRF is the mantra to avoid late surprises. So cemented revision stems can be opted for. The holes can be blocked when cementing is ongoing. The length has to be measured, and they need to be of a modular nature, and they should be sunk a little more than normal. The modularity of the head is important. The cement proximally tends to spill out, and it's not always a very happy affair. So my personal choice is for uncemented revisions, wherein we can use either a cylindrical or a tapered stem. The version has to be adjusted using landmarks other than what are normally used in a hip arthroplasty, more so the distal shaft and the femoral condyles. The proximal bone loss and the proximal femoral screw holes can be very well ignored. The trochanteric reattachment is successful because the good surface of the trochanters to heal. There is no cement to prevent the biological healing. And there are some concerns for stress shielding, but they have not been borne out by studies done so far. So my choice is for an uncemented distal fixing stem when I'm revising a failed proximal femur fixation, primarily because I get better hold in the distal femur, the proximal bone stock is poor, and I am unable to pressurize the cement properly in the proximal area, and the cement does not function well if not well pressurized. THR is an option if situation is such that the acetabulum has been violated, and also in a comparatively younger patient as per their physiological age. Again, the same mantra as we used for the intracapsular neck femurs we discussed earlier. The single most important determinant of success is to reconstruct the abductor apparatus. It is not important to have bony union because the cases in Sir John Charnley's series where he did a trochanteric osteotomy did extremely well, but they did have a flying trochanter in some patients without any symptomatic impact. To repair the trochanter or the abductors, we either use a wire suture or number 5 ethibond as per personal choice. I did a wire suture in my initial cases, but now I'm personally much happier with a number 5 ethibond, and they have to be mobilized under supervision. So some cases to illustrate what we're talking about. This is a 76-year-old lady with a pertrochanteric fracture operated using a DHS by one of our senior surgeons in the city. But you can see at 3 months that there are signs that this is going to not have a very happy outcome. And surely so, it presented to us about 6 months, 4 to 6 months post-operative with increasing pain in the left hip in spite of being kept non-weight bearing and allowing only bed to chair mobilization. This was converted to a distal fixing stem on the femoral side, uncemented, and an uncemented acetabulum. The trochanter reconstruction was done using a number 5 ethibond, and a 2-year post-op follow-up indicates that the abductor repair is still holding. The position of the trochanter has not changed compared to the initial post-op X-rays, and she's a happy lady at the end of it. Another patient where we had uh, pretty simple looking DHS, simple looking IT fracture, DHS used, but look at what's happened. Because of a poor lateral wall, the whole distal shaft has migrated medially, and no wonder this has failed over a period of 4 to 6 months. And we had no option but to offer another distal fixing THR in same similar uncemented stem. Here we reconstructed the trochanters using a wire, and the recovery was uneventful. It is not that only DHS causes problems. A badly done proximal femoral nail can equally cause issues, as was seen in this patient who had a varus deformity causing screw protrusion into the acetabulum, which had to be revised into a total hip arthroplasty. In this case, we opted for a constrained acetabular liner, as this lady was not someone who could be relied upon and was 85 plus. So the family was very clear that it's difficult for them to take care of her. We did opt for a cemented stem here, but as you see, there were no screw holes that we were dealing with. So cement could be well pressurized, and a cemented stem was the option. Another patient who had problems after a reverse intertrochanteric fracture, nailing done, but protrusion of the screw into the acetabulum, revised into a bipolar on table. The acetabulum was not too bad, hence decision was kept to retain the acetabular cartilage, and a Wagner uncemented stem was used to reconstruct the proximal femur extending up to the mid shaft. Another 82-year-old lady who had a DHS fixation with some sort of an osteotomy done seen elsewhere. She was allowed to partial weight bear after the first 4 to 6 weeks. At 10 weeks, it looked pretty promising, but at 6 months, there was progressive collapse of the femoral head and causing the screw to protrude into the acetabulum. And we didn't have any option but to go back to our go-to case of an uncemented total hip arthroplasty using a distal fixing femoral stem, the solution variety in this case, and an uncemented socket. Uh, these are another similar case where we use this. I'm showing this case to show how the bone stock of the proximal femur reconstitutes beautifully around the uncemented stem that was used at just about 3 months post-operative. Mind you, these patients were all put on some sort of osteoporosis medication, whether be it teriparatide or bisphosphonates in the post-operative period. Among the extracapsular fractures, an interesting segment is the unstable reverse intertrochanterics and the high subtrochanteric femoral shaft fractures. These are especially difficult to treat if they are not done so on day one. The main problem is an inability to appreciate the fracture morphology, and the second is the use of the DCS. The DCS has been sort of rubbished by many presentations, and the AO only recommends it for stable fracture patterns because it does not allow controlled collapse and compression and has a higher chance of failure. Now, with cephalomedullary fixations being more popular, I'm sure these results, which we have had to see, are not going to be seen so often. While reosteosynthesis may be a good option in younger patients with good bone quality, in the older patients, my preference is either for a total hip arthroplasty or a hemiarthroplasty. The total hip arthroplasty being reserved for those patients who have a good physiological lifestyle, lucid patient with long life expectancy and higher functional demands. In those where there is a infringement of the acetabular cartilage, there is no option but to do a total hip arthroplasty. Again, the mantra has to be get it right the first time because these patients, the femoral neck is not going to be able to tolerate more than one track due to compromised bone quality. The Swedish registry data also supports the same issues, and they are meant that the conventional length stems have a higher reoperation rate, so you need to use a longer stem. It is important to bridge the previous defects and the holes in the femur, and this data also adheres also averts to a higher dislocation rate with the posterolateral approach. And the last but not the least, it is a surgery which they recommend should be taken up by experienced surgeons. This is, as I mentioned earlier in my talk, also something which is a good alternative in these patients to offer them more stability because of poor neuromuscular function or impaired cognitive issues, a dual mobility cup combined with a femoral stem of your choice. Some examples of these reverse ITs or high subtrox. This is an 82-year-old lady. Fixation was done using a DCS, which is again, in my opinion, an error of understanding the morphology of the fracture. And no wonder in 2 months there was a complete collapse of the proximal femur with the implant failure. A lady was treated with an uncemented long fixation stem, and at 2 years she was doing extremely well and mobile with a single stick. Another patient with a reverse intertrochanteric fracture, 84-year-old gentleman, father of a physician colleagues. He was very mobile with managed medical comorbidities. He had a 7-hour-long operation sent elsewhere for this fracture, and this was his immediate post-op X-rays. Now, you can say that the initial post-op X-rays are suggestive that something is not done very rightly here. The patient was kept non-weight bearing bed to chair transfer for the first 2 months. And at 3 months post-op, he was still non-weight bearing, but you can see here that the screws have started cutting out on the distal shaft. But what is interesting is he's also developing a stress fracture proximal to the proximal most screw, which is seen in the last X-ray here. This was when he presented to me this was 4 months post-operative. He had pain, unable to do an active straight leg raise, and unable to walk either, and literally fed up of the 4 months that he had spent in agony and unable to get around at home as well. So what was the choice here? The choice here was a hemiarthroplasty after discussing with the family in view of the age and the intact acetabulum. The 2 levels of problems were anticipated at the initial fracture site, which was maluniting, and the level of the upper shaft. So we opted to go for a distal fixing uncemented femoral system and followed by abductor mechanism reconstruction. So this is what we chose, a reconstruction with a reef prosthesis, which is a fully coated Johnson & Johnson stem, which has 2 distal interlocking screws to augment the initial stability for the full soft tissue healing and the bone stock reconstitutes. It was hard work intraoperative. There was issues with clearing the fracture site. We did send some deep tissue samples for culture, which were thankfully negative. The version was adjusted, keeping in mind the femoral condyles, and the abductor repair was carried out with number 5 ethic bond. 18 months post hemiarthroplasty, we have a happy gentleman, and you can see how the proximal femur is throwing copious bone around this distal fixing HA coated stem, and he had very good painless movement. And at and at 4 years post-op, his mobility had improved far more, to the extent that he was back to his original situation. Another patient where a reverse intertrochanteric fracture was fixed with a DHS here, which obviously the wrong implant to start with, and she had screws cut out when I saw her about 8 months post-operative. She was offered repeat surgery with bone grafting, but thankfully did not opt for it because she was told that there is a chance that this may go into a further non-union. So when we saw her, we offered her a replacement option, which she accepted. I did an uncemented distal fixing stem and used a circularized wire to bridge this fracture gap. She was very comfortable in the initial post-operative phase and started walking partial weight bearing to full weight bearing from day 2 itself. But pleasantly surprised that 18 months post-op, you could see how well the fracture gap has completely consolidated, and she's back to her original activity level. And she does make chocolates at home, and I get my box every Diwali from her still, which is nearly 5 years post-operative. Another 88-year-old lady treated with DCS implant failure in about 8 months' time, treated by uncemented Wagner's type of stem with acetyl with trochanteric reconstruction using circularized wires, and good healing as time progresses with good mobility restored. So smiles at the end make it worth the effort, but this is something we hope that our newer implant systems and a better understanding of the morphology can avoid, because these patients are elderly, have medical comorbidities, and tolerating a second operation is not in their best interest. So then that brings us nicely to our last part of our presentation as to what is the role of a primary arthroplasty for unstable extracapsular fractures. So we discussed this earlier that we cannot always apply Western results to us, and we're talking about unstable trochanteric fractures. I'm not at all talking about the 2 and the 3-part IT fractures. They are doing very well with fixation, better with the cephalomedullary nails than the DHS, but that's a different topic. But we are talking here about the unstable trochanteric fractures. These fractures of these patterns, when there's a posterior medial wall blowout, quality of bone is not very good. The trochanter GT is separate, and it's a 4-part intertroch. Fixations options, as I said, are either a DHS or a proximal femoral nail. The fixation obviously has advantages. It retains the natural hip. The chances of dislocation are not there. Patient can resume normal activities without any hip restrictions pretty fast, and there's not much blood loss. But that does not happen all the time. These unstable fractures have inherent problems. There is a posterior bone loss. There is comminution, which can be severe. The shattered lateral wall. They may have a reverse oblique component, and sometimes they have subtrochanteric extension as well. The importance of the lateral trochanteric wall has been well written up in articles and cannot be ignored, especially when you're using a surface implant like the DHS. So what are the problems with internal fixation? The fixation failures are probably due to osteoporosis being major component in these patients, and lack of medical management either pre-operatively and also post-operatively. Inherent fracture morphology lends itself to being susceptible to failure, whether lateral wall blowouts or instability. Poor techniques, as these are sometimes done by the junior most residents, with inadequate reduction and the TAD not being respected. Surgical inexperience is also a part to play. And if you have a fixation which is not very uh, good, then you have to mobilize these patients slowly, and that itself has its own problems. Not all unstable fractures require to be replaced. As I said, the cephalomedullary implants are doing extremely well, And I, for one, I'm quite happy with the proximal femoral nailing systems available in the market, and they make up for the fracture patterns in the bulk of patients. But when you see these type of disasters, which have then to be salvaged to internal fixation, you do think whether there is a role for surgery, and this is what we also refer to as the coxofemoral bypass. We owe to Dr. Lard, who has given us this terminology, and it is being offered as an option now in some select patients who are in their 80s or above for very unstable extracapsular fractures. Literature has now come out in extremely good support with good papers coming out supporting the role of arthroplasty as the primary treatment. And all these papers are all focusing on the femoral side as the reason where we need to convert them into a primary arthroplasty. So we're talking about elderly population, which is more than 80 years of age. Primary arthroplasty allows us early mobilization, improved rehabilitation. The medical comorbidities are better managed as it is a single surgery and a definitive surgery with a higher predictability of success. The potential problems doing a THR or a bipolar in this group are essentially femoral. The bones are porotic. The proximal bone stock is mostly not there. There are altered landmarks. The abductor mechanism is all around the place. And the fit of the stem has to be proper to allow immediate stability. So there are a few surgical steps which are important when we embark on this procedure. First is to make use the available landmarks to measure the length and how much of the implant has to be sunk in. The opposite leg can be a good guide. You need to sink the implant a little more than what you think you should, and then adjust with the modularity. Both lateral and vertical offsets need to be restored to achieve adequate soft tissue tension. An unstable arthroplasty in this group is a disaster and should be avoided at all costs. So that is the final thing to take home. You cannot leave these patients whom you're taking up for a primary arthroplasty unstable in any direction, whether it's vertical or lateral offset. So the stem version is determined using mainly the femoral condyles and the distal shaft, as the proximal landmarks are not really available. We have a small case series of about 30 odd cases where we use bipolar hemiarthroplasty in most of them. Cemented and uncemented stems were both used, as we'll see further. Meticulous abductor repair was done using the wires or ethibond sutures. All patients were mobilized about 36 to 48 hours post-operative, initially with a walker as tolerated and converted to a walking stick anywhere between 3 to 6 months, depending on how they coped with the walker, as they were all in their mid-80s or 90s. The fracture patterns which lend themselves to a primary arthroplasty are something of this, which are unstable with shattered lateral walls and unstable proximal femoral geometry. Dodgy lateral wall in this, you can be sure that if you try and fix this, you're going to have a complete lateral wall shattered, or chura as we call it, in your hands, and then the problems start. Unstable fracture geometry, like in this patient who had both an extra and an intra-capsular component, which we treated with a cemented hemiarthroplasty with trochanteric reconstruction using wires, and you can see how well the abductors have healed up. Meticulous abductor mechanism reconstruction, and I cannot be more uh, precise in saying that this is the single most determining factor as to how this operation is going to succeed or fail. So we used wires, as you see in these two cases initially, or now we are using ethibond sutures, as these two cases clearly indicate. Whatever we use, we have to be sure that our abductors continuity is maintained for good stability. Bony healing is a bonus and not the absolute criteria. But if you have situations where we have poor abductor repair, then this is inevitable. Luckily, not my patient, but something which can happen in the best of hands. Another case where the abductor repair was not very happy, the surgeon was not very happy on table, and no wonder it came out in less than a week with the clips in situ still seen. So if you're doing a primary arthroplasty, what type of prosthesis do we use? Well, you can use a cemented calca replacing prosthesis, which is my favored choice in those patients who are pretty old with poor bone stock, but who are pretty okay in terms of medical comorbidity. So this is a stem I use. This is a cemented calca replacing stem, locally made, of course. It has got anchoring holes in the proximal box that has been incorporated, wherein the abductors can be repaired using those anchoring holes, similar to what we use in the proximal femoral, proximal humerus arthroplasty to repair the greater tuberosity. This is few examples using this calca replacing cemented prosthesis. The Indian version was what I showed you. This, if you have somebody who wants an imported implant, a couple of imported companies, especially Smith and Nephew, and maybe Zimmer, also have such innovations. An 80-year-old with an unstable intertrochanteric fracture, treated by a calca replacing cemented prosthesis with abductor repair using wires. Another lady, 91-year-old here, primary coxofemoral bypass done using a calca replacing cemented femoral stem. And another lady, 86-year-old, and you can see the 2-year follow-up, how well the soft tissues and the bone have healed up around the proximal implant, and she still remains mobile with a single stick. Sometimes you can get away using a conventional bipolar in those which do not have a very major posterior medial cortex comminution. Uh, in those cases where you're not sure whether there's an intracapsular component, a CT can sometimes be done to reconfirm it. But if in doubt, it's best to replace, because these patients are not going to tolerate a second procedure under anesthesia, and comorbidities are too high in any case. So another patient where the posteromedial cortex was not too bad, but the fracture geometry proximally was not very conducive to fixation. And we did a conventional bipolar here, a cemented stem, no doubt, with abductor mechanism repair using wires. Another patient where we opted for an uncemented but a conventional length stem rather than using a calca replacing or a longer distal fixing stem. Uncemented long distal fixing femoral stems are also an option. They are used in cases where you are keen on avoiding the cement implantation syndrome, or in situations where you want to avoid cement because of medical comorbidities. The femoral cortex, however, needs to be pretty good here to get a primary distal fix. So another example of a distal fixing stem used for primary arthroplasty with abductor repair using wires. Another couple of cases where we've used number 5 ethibond to repair the abductors, but have used a primary distal fixing uncemented stem rather than using a calca replacing cemented stem. 2-year follow-up of a patient using the uncemented distal fixing stem again shows excellent bone restitution proximally uh, around the greater trochanter. This is my poster girl, 94-year-old lady, done a coxofemoral bypass, and this is her picture at about 6 weeks post-operative. I could not dream of having her mobilized like this if I had done some sort of fixation with her poor bone quality. And the lower video shows her walking at about 3 months post-operative. We do mobilize them slowly, but they are up early. They use walking aids, and after a few months, sometimes they're able to walk even without it, as this brave lady just demonstrates. But I still prefer to have them with a stick. She was a bit of a tough character, not wanting anything to hold on to. But every day is not Sunday, so nothing shatters confidence like critical follow-up, was one of my boss's oft-repeated statement. So this is a lady who had a primary arthroplasty for a bad proximal femur fracture in her mid-80s, but at 5 weeks post-op, she dislocated. Now, I thought I had done a good job for abductor repair, but obviously things can go wrong. And in her, it was more of a psychosocial background with nobody to really care for her, which happened while this happened. And she was also not somebody who could be very lucid in following instructions. So the only salvage option for me was to retain the same femoral stem and convert the bipolar into a constrained uh, total hip replacement using an uncemented socket. Another patient done seen elsewhere who came to us with a dislocated bipolar following uh, failed proximal uh, femur fracture converted to a hemiarthroplasty. In this, we had to use the liner, the cemented a constrained liner into this because her acetabular bone stock was very poor to allow me to anchor a uncemented socket as such. So I had to use the constrained polyethylene liner as a cup, roughen up the posterior edges and cement it in. These are all salvage options which are best avoided, but you should be aware that things can go pear-shaped even though you intend to do them right on day one. A couple of lessons I learned was that if you're offering a patient a hemiarthroplasty, you have to be sure of the psychosocial status. This lady was demented, 90-year-old. I would have otherwise offered her a primary arthroplasty, but because of a psychosocial assessment, including poor caretakers at home, I opted for a fixation, kept her in bed for 6 weeks before mobilizing her, and she had an uneventful result. So all these patients start full weight bearing on the affected side post-op. Uh, Bipolar or low mobility are preferred in these cases because of poor soft tissues and are now being more used in cases which are of the older age group. So in conclusion, arthroplasty is an acceptable option in carefully selected cases in the elderly population. It is very demanding, so an experienced arthroplasty surgeon is needed. Either cemented calcar replacing or uncemented distal fixing stems are both used to offset the proximal femoral bone loss. Early mobilization and lower failure rates are compared with internal fixation in unstable fractures. So before signing off, I would like to leave you with this thought. A hip arthroplasty in trauma needs all the principles of joint replacement surgery with a better understanding of the soft tissue tension principles. Salvage arthroplasty is challenging, needing an experienced surgeon aware of the available options and a plan B to fall back on. Failure to plan is planning to fail was never more true than in case of hip arthroplasties done in complex trauma scenarios. Thank you very much. I hope it was.
Yeah. Thank you very much. Thank you very much, Dr. Girish Dewnany, for such a comprehensive coverage. I have not seen in the last 45 minutes what you have showed, so many number of cases which you have done in your lifetime. I have not seen so much complication in my life. Lucky for me, touch wood. And I don't want to see so many complications. However, I want to ask you one or two few questions. Many complications you showed were because of improper fixation using a DHS or a DCS. And in the last, I think 7 to 8 years, or at least 6 years of my life, I have only done 2 or 3 DHS for an IT fracture, that too maybe a type 1 fracture. So we nowadays commonly do PFN-A2, which you had shown one complication of a proximal femoral nail also, where the nail had, where it was not a proximal femoral nail A2, it was something like a screw type of nail. So have you seen any complications in recent times of PFN-A2?
We are finding less complications, but not, I would not say zero, because the principles of PFN-A2 are that you should not use it unless you have a proper reduction. So in cases where it is used without getting a proper reduction, it is going to behave or fail the same way as a DHS does. And secondly, all the principles of PFN-A2 are not yet followed by people. Every PFN-A2 you do, you keep a DHS standby, right? So that means the DHS still has a place. So if you have a patient who has a shattered lateral wall and fractured geometry which is complicated and you do a DHS without doing all the principles, you're still going to have a failure. So, and these patients are still very porotic. So the principles of fixation are one, but you have to also understand that they have to be treated for the underlying porosis. A lot of patients are operated DHS or PFN or whatever you have done and forgotten. No, you have to monitor them for porosis, otherwise your implant is going to fail because the bone is not good. So only if you have a combined medical management in addition to good implants, that we hope that these cases will decrease. But there's still quite a few being done. And remember, it's an aging population. You are going to have more and more patients living beyond the age of 80. So this are going to happen. That is why this new option of a primary arthroplasty, sometimes you feel that it is better to just give them an arthroplasty on day one and not risk these failures. So these are both sides of the same coin. Whichever you choose has to be done with care.
Yes. So I want to ask you regarding little bit of medical management also. Now we are on that topic. So once you have done an arthroplasty, you don't require, most of the time you don't require a fracture healing, or even if you require, like sometimes when you're using ethibond for the GT, do you always start them on teriparatide, especially if the patient is above 80?
No. For a patient whom I'm doing a primary replacement, I do not start them on riparatide. I rather give them either a zoledronic acid or a bisphosphonate therapy to improve their bone stock. I personally prefer to reserve the teriparatide in those cases in which I'm doing a fixation, whether it's a PFN A2 for or a long PFN, because I have not done a DHS for the last 5 years, thankfully. But again, they have to have normal PTH values, calcium, vitamin D in normal range, and then they get a teriparatide protocol. Whether 6 months or 2 years is debatable. It is off-label use, but personally, I have found it quite helpful in my practice. But you cannot give 6 months of teriparatide and forget it. You have to maintain it with bisphosphonates to preserve the reconstituted bone. So medical management of porosis is very important, that it is understood by all treating trauma surgeons doing hip fractures.
So have you seen that basically these things, do they work actually? Because you know what, yesterday only I have operated a patient for a distal radius fracture which was massively comminuted, and with the same patient I had operated 1 year back for a IT fracture with a PFN-A2. So 1 year back when she was operated, I had started both teriparatide as well as denosumab, both together. And it's been 1 year she's been taking it now dedicatedly, because she's also one of my family friends. So she's taking it regularly. She's 86-year-old. In spite of that, I couldn't prevent the second fracture. And second fracture was just slip in a room, very, very low energy.
No.
I really don't know whether these things work.
These things work, but they are not the only things that work. If you see her bone density scan, it may have improved with these things. These things decrease the variables. They do not abolish the variables. The bone quality is not going to go back to what she was when she was 36. The bone quality remains poor, but the chances of her having more problems will decrease when you have appropriate therapy installed. So I think it's not right to say they will abolish the fracture risk. They will just decrease the fracture risk. And in each individual patient, it is a toss of the coin, depending on how they have fallen and what is the initial bone density to start off with. So I think the risk of a second fracture is so much more in those with a primary fracture. These interventions just decrease that risk but do not abolish it. So I think they still have a very big place.
Okay. And now coming back to your trauma scenario. So in an IT fracture, as we were speaking about PFN-A2, we have now, after the PFN-A2, we are now set, because in the last few years, now we are able to understand where we should do the PFN-A2 and how we should do it. So do you still do the coxofemoral bypass, or you have given up in the last 2-3 years?
No. I still do the PFN. My the frequency of the coxofemoral bypass has certainly decreased with a better implantation available, but still there are certain amount of cases where there is a shattered proximal femur, where you know that if you're going to put a PFN-A2, you're going to put them in bed for 6 weeks and you're not going to be sure how to mobilize them. So in those, I would still go in for a coxofemoral bypass. Secondly, there are cases where you may see a IT fracture on first sight, but if you see more closely, or if you do a CT, you may find some hint of an intracapsular element. then I will then go in and do a coxofemoral bypass, because then you are facing a risk of an intracapsular problem, and these patients are certainly not going to tolerate second surgery. I reserve coxofemoral bypass only for the 80 plus, and nothing below, nothing younger than 80. Everything younger than 80, more or less, most cases will get a PFN fixation unless they are convincingly showing me a intracapsular component on the CT or on their lateral x-rays.
So last question, that many patients who come to me above 70, they say that I am 75, 76, and they are not ready for first surgery only, where they are to basically give a fixation or whatever. So how do you convince them for a second surgery? Because it is really difficult that basically whether the first surgery was not successful, how do you basically say that the second surgery, what is the chance of the second surgery being successful?
So you're telling me that you're talking about a failed proximal fixation, right?
Yes. Who's
Yeah.
already basically very difficult to take on the table, that they had decided, they took 3 to 4 days to come on the table.
The failed proximal fixation patient is going to be miserable.
Hmm.
They are going to have more pain. They're going to be immobile. They're going to not be able to do their daily activities. So it is not difficult to sell them the second surgery. However, they are very categorical. They don't want a surgery which has a chance of not healing. So that is where the predictability of the operation comes in, and that is where they agree for surgery depending on their symptoms. It's like the TKRs or the THRs. When they come for revisions, it is because they have no other option. They have waited it out. They have taken 25 opinions from 35 doctors. So when they come for surgery, they do not want an option which is a refixation, because I am a strong believer that in the femoral neck, in a osteoporotic bone, once you have one tract of the DCS, DHS, PFN, whatever you have, you make a new tract, it is going to be a recipe for disaster. It's going to cut out. The bone is not good enough. So you there have to offer them hemiarthroplasty or total hip. Refixing a failed proximal femur fracture, whether it's intra or extracapsular, is complete no-no in my book at least. So that is how you have to be very clear. And they have a higher chance of dislocation because their abductors, etc., are not good. So it's a technically more demanding surgery and has to be done with that much more care. That's why I said the abductor repair is the cornerstone of success. And sometimes you may do a dual mobility total hip for a patient if you feel that they are more likely to be unstable with a pure bipolar. So that decision has to be taken on table. I've just done a case 1 week ago of an intracapsular neck femur in a patient with Parkinsonism and dementia. It was 79. I did a primary dual mobility total hip replacement using a cemented exeter stem and a dual mobility uncemented cup. So you have to now offer them, as we call, horses for courses, depending on what is the scenario, fracture wise and patient profile wise. These patients are going to come, people are living longer, these problems are going to increase. So you have to have a clear thinking process as to where you will offer what.
Okay. So thank you very much. We thank Dr. Girish Dewnany to spare his precious time and spend time with us, showing and discussing all the various type of difficult cases which we may face in the coming future because of patients sitting at home for a very long time and they started having osteoporosis and even more so. And we thank Dr. Reddy's lab, the makers of Ultranise, Nise Gel and Omez, for bringing us this webinar. Thank you very much and good night to all of you.
Thank you very much.
Good night.